this morning, he is going to be talking about his perspective on creativity and innovation, a personal perspective. Dr. Clayman?
This talk is just a general talk to have you think about a few things. I'll give you a couple of examples of innovation, but what's more important in this talk is for you to think about yourself and what your own personality is, what your own personal traits are, what your own strengths are, and begin to think about that from the standpoint of creativity. And that's the most important part of this talk as far as I'm concerned. So there's one thing that sort of occurred to me a few weeks ago. I was working on this, and that's the idea of the career. And everyone in this room has a career, but a career in medicine is really, really special because you've got the privilege of taking care of other human beings, and you have or should have an insatiable desire to relieve pain and suffering. And in that mode, if you will, for all afflicted individuals, this is an ongoing crisis that actually begs for your innovation. How can you decrease the amount of pain and suffering that you are forced to visit on another individual in order to cure them of the disease? This is no different than going back to the 1840s and the beginning of anesthesia, and why John Collins Warren elected to allow William Morton to proceed with the first administration of ether anesthesia. So I'm going to cover these topics, these, if you will, 5 areas in the next 40 minutes, going over just a simple definition of innovation, the concept of a seminal why, the factors for getting to innovation. I'll give you 2 examples that I've been fortunate enough to experience, and then a little bit on creativity in you as far as what are your creative brain sets, and a bit about the importance of mentors. So John Calhoun gave this definition for innovation is where creative thought, practical know-how meet to realize value by doing new things or old things in new ways. And I would stress by people who are open to change. And that's key. So what's the best question in the world? I think the best question in the world is the ability and the opportunity to ask why. And I think that's one of the strengths of the system, at least in the United States, where you are given the privilege of asking why. Somebody tells you something, you show why. Why am I doing this? Why are we doing that? And that individual, it's incumbent upon them to give you at least a reasonable answer other than because I said so. Paul Lang, who's a good friend of mine, said, curiosity is what separates us from most of the other groups that minister to the suffering. It's the bedrock of scientific process, and without it, medicine as we know it could not exist, nor could we anticipate future progress. So that's why. The question is, what's the seminal why? So the seminal why is a disruptive question that's born by clinical consternation or empathy that ignites within the individual surgeon or internist creative thinking. That's a seminal why. When I give this talk to medical students, I say, well, you know, the way to identify a seminal why is a question that generates the greatest negative response in the most senior faculty. That's the seminal why. Because that question probably threatened the entire specialty. So if I were to have been a medical student and I asked Pat Walsh, why can't we do prostatectomies with a robot? I think he probably would have broken both of my knees and sent me away. All right, why? Because that threatened the entire way things are being done now, and the entire way that a lot of people, in a nice kind of way, are making their livelihood. That's the seminal why. For innovation to move forward, there are 3 considerations, okay? There's an emotional, a practical, and then a personal and personnel consideration. And again, I go back to John Cow, who gave a lovely talk on this. And the emotional, there are 3 factors. What's your vision of the desired future? What's the purpose of the journey? And is there a sense of urgency in doing this? The practical are, do you have the time and energy to seek the new? Do you have the time to discover? And if you have the time to discover, do you have a way for the innovation to co-evolve with your day-to-day work? Do you have protected time? So if you have a lab, that's great. But if you don't have any time to go to the lab, you don't have a lab. And so do you have the protected time to develop what you've discovered? And then lastly, do you have a way to steward what you've discovered so that you can disseminate it, moving on out? So the personal and the personnel comes down to basically, who are you? What are your personal strengths? There are 4 basic areas. Are you an ideator, developer, an implementer, or a clarifier? And there are definite traits for each one of these. Now, no one person that I know is all 4 of these. Some people may be 2 of these. Rarely you might find somebody who has traits that would fill 3 of them, but not all 4. And so what this is really saying is, if you're going to innovate, you need a team. It's a team approach. So Apple, Steve Jobs, people who are crazy enough to think they can change the world are the ones who do. All right, an incredible ideator and an incredible implementer. But without Wozniak, Jobs was going to basically do nothing more than harvest apples somewhere in Oregon. You needed Wozniak, who was the brains behind developing the first Apple computer in 1976. So Wozniak served as the clarifier. So it's a team sport. As Jobs was the ideator and implementer, Wozniak was his clarifier and developer. And with that, they were able to move forward. So again, throughout all this, you're going to see, if you're going to move forward, you need a team. And the team is what's key, not the individual. It's always the team. So if indeed you only have an ideator and implementer, Gary Larson said, well, this may happen to you, you know. Zog, look, we're going to be able to capture a saber-toothed tiger. They had a clarifier and a developer, they wouldn't be sitting in the box. So Malcolm Gladwell said, well, there are 3 phases in order to get to a tipping point. Watson, come here, I need you, there's the telephone. Nothing's the same again. In order to get to that tipping point, you need those 3 phases of development of innovation, which is the discovery, the development, and then most important of all, you've got to disseminate. Because discovery and development without dissemination is just a magic trick. So this is one area. I have 2 that I'll show you. I mean, obviously, this is the one thing that I've become fairly well known for, is the laparoscopic nephrectomy back in 1990. So this is just a matter of taking what is there before and building on it. Laparoscopy goes back to 1901 with Kelly, a general surgeon who wanted to see if he could stop bleeding from gastric bleeding in dogs by creating a pneumoperitoneum. And he did, raise the pressure to 100 millimeters of mercury, and lo and behold, there was no more bleeding. And he took the cystoscope, stuck it in the abdomen so he could see. Took 9 years before Jacobius, an internist, said, hey, we can use this in GI for diagnosis. And then basically not much happened with this until Sem got a hold of this in Germany in the 60s and pushed it forward, really pushed it forward. Amazing that this happened in Germany. And in point of fact, in 1980, as I'll show you, when Sem did his appendectomy and got kicked out of all these societies, the chief of his OBGYN department forced him to undergo a brain scan because they truly believed he had a tumor. That's a fact. 1985, Mui did the gallbladder, and again, tremendous resistance from this. And in point of fact, Mui was actually brought up on manslaughter charges because one of the patients died. The case took 3 years before they cleared him. So people are not too happy sometimes with innovation. So Cézanne's kiss of the muse. You've got to recognize when that muse sits on your shoulder and all of a sudden you go, wow, that's an interesting idea. So what happened is Lou Cavusi and myself were working with Nat Soper, general surgeon, doing laparoscopic gallbladders in pigs with electrocautery. Because up until that point, people said, oh, you needed a CO2 laser, and that was convinced that electrocautery would be safe to use in the laparoscopic field, that there would not be an explosion as people said there might be. And so I had laparoscopic equipment. Nat had a need to do this. And so urology and general surgery got together. And all the time that Lou and I were working with Nat, taking out the gallbladder in the pig is not bad. There's no fat in the pig. The kidney was just sitting there going, hello. And so Lou and I said, well, can we take out the kidney in a pig laparoscopically? And that's where that all started. But again, this goes back to 1869. This gentleman, Gustav Simon, first person to remove a normal kidney in the lovely Frau Margarita Kleb, who had a ureterovesical fistula, ureterovaginal fistula. Not much has changed from 1869 to 1990. So let's look at the factors, though, that were operational. The emotional factors for nephrectomy were there. Effective renal surgery, less morbidity, quicker convalescence. The urgency was there because every day people were undergoing major open operations. The practical considerations for us were there because thanks to Bill Catalona, I had protected time. I also had a laboratory in which I could work. And we had some companies that were working with us that would allow us for something to develop that they would steward with us. Personal factors were there. I was blessed to be working with Lou Cavusi, along with Steve Dirks, who was a resident, Shimon Meritek, a fellow, Stephanie Long, who was our lab director. And as far as a clarifier, Nat Soper was superb. Nat's now chief of surgery at Northwestern. And then we were really blessed in those days with Cook Urology that was very, very much into innovation. This gentleman, Fred Romer, directed the team, and with his engineers, Paul Thompson and Ed Pingleton, they were coming out to St. Louis to work with us to perfect the technique for doing a laparoscopic nephrectomy in the pig. In 1989, I spoke with Fred at an AUA and told him we were having some problems because we were working on this, and lo and behold, we thought it really slick. We could take a pig kidney out in 2.8 hours. We thought that was really cool. But the problem was at the end of doing this, then we made an incision and we pulled the kidney out. We went, this is really stupid. We just spent 2.8 hours to take the kidney out, and at the end of it, we made an incision to pull it out, so there was no benefit to it. And so the idea came up of entrapping it. We started to put sacks in through the 12mm port. They tore, they didn't work. And eventually, this is literally a sack from it came with a pair of Patagonia running shorts. The sack got a bigger workout than the running shorts. But with this, you could then pull the strings up through a 12mm port, pull this up to the skin. And then we were making a smaller incision to pull this out. And then we said, well, why don't we morcellate? And we went through orthopedic shavers and a bunch of other things. And I was explaining to Fred that this was a real problem because we could not find something that would efficiently evacuate the sac. Well, this was a gift of the Magi moment because Fred was related to me that they had developed a morcellator for OBGYN that basically worked on suction. And the problem is, as soon as they put it in the pneumoperitoneum, they sucked out the pneumoperitoneum, they could see it. So the perfect marriage was an impermeable sac. And so Fred sourced the material out of which the lap sac was made, got this lap sac made out of an impermeable material. And this was the morcellator back then. This would hook on the suction. The tip had a recessed blade that was spinning at about 5,000 RPMs. And so you just sucked the tissue in. And as long as there were no folds in the sac, all the tissue came out into the base here, into a trap. So I was presented with this woman, 85 years old in 1990. She had this 3-centimeter renal mass, okay, which today would be a partial nephrectomy, but back then was a radical nephrectomy. She was very frail. Her internist sent her to me, and she had been basically, they were afraid that she could not be operated on. So we thought this is something we could do. My thinking was, well, radical nephrectomy or nephrectomy has been around for 150 years. Laparoscopy been around for over 100 years. This seemed to just put two techniques together. So I did need to do informed consent. And I spoke with a patient who was a lovely woman, unmarried, no family, who had, as everyone in this room experiences at times, ultimate faith in your ability to do anything you wanted to do. So if I told the patient, listen, we're going to fly you to the moon and back, it would have been, okay, doctor, that's just fine. And so I had her bring in her best friend so I could give informed consent to the best friend. And the idea was that if we had problems doing the case at any time, we're just going to open. About 2 nights before we were planning to do this, for whatever reason, I had the good sense to dial up Dr. Catalona and say, hey, Dr. Catalona, we're thinking of going and doing this. And his response to me was, get IRB approval. I went, oh, IRB approval? Kidding me? You know, he said, listen, if it goes well, you'll be fine. But if this turns into a problem and you don't have IRB approval, you're dead. So we called up the head of the IRB, explained it to him, and they gave us approval to do 2 cases. But Bill was right. This is actual footage from 1990. The patient had the kidney embolized in the morning of surgery, came down to the OR at about 3 in the afternoon. We insufflated with her on her back and then turned her. This is the state of your visualization with the instrumentation. It was extremely difficult. We had put up a ureteral catheter, and that's the only thing that saved us. The only thing that worked well was sacking the kidney and using the morcellator to get the get out the pieces. It took us 6.5 hours or 7 hours to do this. We get a great picture here of Dr. Kavusi. That is intent concentration. So this finished up around 10:30 at night. No one had ever done had a pneumoperitoneum for that length of time. So she became severely oliguric. She developed a dilutional anemia and some congestive heart failure. We did give her, I think, a unit of blood and diuresed that off. She went home several days later. Pain-wise, she only required 3 milligrams of morphine sulfate. Went home on post-operative day 6. And so again, we used the lap sac and the morcellator for this. That's the tissue that came out. The pathologist was able to make a diagnosis on that. They didn't like that, but they were able to make the diagnosis. And this is what her abdomen looked like because we had morcellated it. There was no incision on it. One here, one there, there, and there, bigger than a dime. And then we learned that God has a really bad sense of humor because the pathology came back oncocytoma. So she never needed the procedure in the first place. Today, our place, this would have been a biopsy and you would have left this alone. But such is life. In rapid succession, then came retroperitoneal nephrectomy. At our place, 1990, and then 91, we did the nephrectomy. Sherp Figgenshaw worked it out with us at the bench, and we did it at the bedside. 1993, Elspeth McDougall, we were working in the lab doing partial nephrectomies. Howard Winfield, a former fellow at the University of Iowa, was fortunate enough to come up for that first case, and that actually went well. I vividly remember Dr. Williams walking in the room and asking us why we weren't clamping the vessels, and we went, I don't know. At any rate, fortunately, it was benign kidney and it worked out fine. It was her stone. And in 94, Indy Gill actually came out to our place to do a year of lab work or 6 months of lab work. And we were thinking, could we do donor nephrectomies this way? Indy showed you could take out a kidney laparoscopically in the pig and reimplant it, and it would work. And then in 1995, Lloyd Ratner and Luke Kavusi at Hopkins did the first donor nephrectomy laparoscopic. The question is, when do you disseminate something? Yeah, it'd be nice to do a prospective randomized study. That's not going to happen with surgery. Patients, as a rule, aren't going to sit still for that. So you're left with retrospective reports. And I always look for what I call the 4 E's. Is it efficient? Is it effective? Is there equanimity there? In other words, quicker convalescence, less pain, and is it economic? And I think if a new procedure has all four of those factors, that new procedure will go forward. Over the years, in point of fact, it became pretty clear that the laparoscopic was a way to go. Less blood loss, less use of morphine sulfate, shorter hospital stay, fewer complications, quicker recovery. As far as the overall effectiveness of the procedure, no evidence of disease was certainly equal or better. And there's some reports now showing that it's actually better. The only thing was it took a little bit more OR time, and that came down as people became more facile. And in the long run, you were saving $1,000 a case. So yes, disseminate, and the dissemination is a hard lift. That's the courses. And you're going to spend hours upon hours teaching other people how to do this if you really want to disseminate. And that's what we were doing at Washington University for quite a while. That's Steve Nakata, who was one of the guests of one of our courses. And again, it then disseminated finally, but it took close to 10 years. So the second innovation is a lot more undeveloped, and that's the force sensor that we discussed a little bit yesterday. We do like these access sheets. We're using them a lot. We believe that they really do facilitate a case, allows you easy access to the collecting system, maintains low intrapelvic pressure, decreases urosepsis, improves your stone-free rate, and actually saves you money. The biggest problem remains, again, the split. And these are horrible looking pictures. And whether it's 2013 or in 2020, really skilled endourologists are still splitting ureters when they put up an access sheath in upwards of 20-some-odd% of patients. And this is only with a 14 French sheath. At our place, we routinely put up 16 Frenches. We put those up in close to 60% of our patients. So the muse returned, and the question came up because I was in the OR with Dr. Kaler, and we'd done a case and we were patting ourselves on the back. The stone was out, things looked great. And then as we looked at the ureters, we pulled the sheath out, we went, oh, there's a split. And one of us looked at the other one of us and asked, well, how much force does it take to split a human ureter? That was the seminal line. So thanks to Cam Kaler and his question, or my question to him, and I can't remember who asked who, but the bottom line is we said, well, let's find out. Developer, we had Mike Klopfer, who was at our School of Engineering, a wonderful engineer, willing to work with us and develop a force sensor, and Steve Chang, who then was willing to work with us and actually reduce the size of this force sensor. And then Pengbo Jiang, former fellow and now faculty at UCI and our Curiosity and Innovation Laboratory, we continued to push this question through. The emotional factors were there. Certainly, bigger sheaths would allow for more efficient procedures, and we would eliminate ureteral injuries, possibly even eliminate the need for ureteral stents if it went up with very little force. And the urgency was there because every day 20% of ureters were getting split when people were putting up a sheath. The practical considerations we had, I had protected time, as did our fellow. It could co-evolve, if you will, because we had a great laboratory, and we could partner with people in our Samuele School of Engineering in order to develop the device. And so this I showed you, I think, yesterday. Again, it just abuts on the end of the sheath, and as you're pushing, it measures the force in hundredths of a newton. And as it gets more force, it goes from green to yellow to red. With this, we could actually determine how much force you're putting there. And as I mentioned in our talk yesterday, we found out that basically 6 newtons was a sweet spot. We didn't want to go out above that. We found that out in pigs, and then we transferred this to a human study. We've done over 200, we've done 250 adult ureters. And if you stayed under 6 newtons, you weren't splitting ureters. If you went above 8 newtons, that was where we began to see problems. And so at 6 newtons, We weren't splitting anything, and at 8 newtons, we could see a problem. We got 16 Frenches up in 58% of the patients at less than or equal to 6 newtons. Most of our patients do get tamsulosin for a week prior to their procedure. Again, no serious injuries at less than 6 newtons. This turned out to be in agreement with the work from Korea by Koo and colleagues, who also noted a 6 newton limit. We had 2 splits in this series, but in both cases, 8 newtons had been exceeded. No serious major splits, but again, when we get a split like that, we leave the stent in for at least 2 to 4 weeks. So the original force sensor is just too big and too unwieldy. So you needed to reduce the size of this thing that's bigger than your hand. First iteration was this. We actually built a black box into this. So if you went above 8 newtons, you recorded that. We decided this would not sell well. And it was still too big and too expensive. And so this is now the latest iteration. It's down to the size of a 10 cc syringe. It's got a spring that will basically, as you push in against the access sheath, there's a window here. It'll be green until you hit 3 newtons. It'll turn yellow when you hit 6 newtons. And above 6 newtons, it'll start to go red. And if you get all the way here, you're basically at 9 newtons. And so this is currently in development. We're working with one company on the East Coast to see if we can get these produced. But that's the discovery and the development. Development phase is still very much active. You know, we've just submitted a patent on this. We've have some prototypes for testings. We've done some clinical trials, but we'll have to redo these with the commercial product. FDA filing would then follow. You need the money to continue doing this, or a company that's willing to back it. Fortunately, we do have one company that is significantly interested, and I think is going to license the technology. Dissemination is nowhere. You know, we don't have anything to disseminate. But my hope is that this would be very easy, that it'd be very inexpensive, and would give more people the opportunity to pass a larger sheath and actually do a better job for their patients. So is this a one-off? I don't believe so. So pardon a little bit of hubris. But it's the beginning of a concept of looking at science of surgical force. So how much force does it take to perforate the subclavian vein when you're putting in a CVP line or the vena cava? How much force does it take to perforate the aorta? How much force does it take to perforate the esophagus when you're doing endoscopy, or the colon? How much force does it take to perforate the human ureter when you're passing a Foley? And why don't all of those various instruments have a force sensor attached to them, which will preclude any physician, anytime, from perforating any of those organs? Just a question. So, second part of this talk is really about you. What about creativity in you? If you're interested in this, get this book. Shelley Carson wrote a book on your creative brain, 2010. You can go online. There's actually a test you can take, and it will tell you what your state of mind is, if you will. Break it down into these 7 factors. There's 2 major things here, 2 pathways, a deliberate and a spontaneous. And the deliberate is really the area, if you will, of somebody who really is a great clarifier. That's reason and evaluation. The other 5 are more, if you will, in the spontaneous area, connecting divergent thoughts, the ability to envision things or image, the ability to absorb knowledge. The other thing that I love is this transform, which is the ability to take negative results and use them for positive purposes. And then the spontaneous thing, or the stream, is when you're just working and you have no idea the time is passing. I can tell you back in 1990, when we were in the OR, nobody realized how much time was passing. Nobody. Just was there. Suggestions and musings from a few famous people with regard to creativity. Pablo Picasso said, "Without great solitude, no serious work is possible." So if you're really going to create, you're going to need some quiet time. And so find some self-time where you can just be by yourself for an hour without the pager going off, the beeper going off, this happening, that happening, where you can actually just sit for an hour and just think. At Washington University, I actually found a place where I could quote unquote hide, which where all the interns and residents did their dictation. I would go to the resident dictation and sit with Carol, and nobody knew me from Adam. And I could think for him. If it gets really bad, you can schedule bogus meetings with yourself. But there it is. It actually got to the point at WashU that what I eventually did is I just told my AA, block me out every 6 weeks for the next year. Just block me out. Just go through the calendar every 6 weeks, block me out. No patients, no OR, nothing. If it falls on AUA or whatever, then that's fine. But the bottom line is I need to know that at the end of every 5 weeks, I have a week that I can actually do something. So that's the lab week. Find a place at work to hide. Again, by the way, people said, oh, geez, if you do that, your income is going to go down. You're going to get punished financially. This is no different than playing a sport. When you're in college and you play a sport, you got 2 hours or 3 hours out of every day with that sport, and all of a sudden the season ends, and you're no more efficient than you were before. That time just seems to get frittered away. My experience was that this did not cause any decrease in the amount of patients I was seeing. Final act is a singular activity or event based on all that has been consumed and communicated. But again, this may happen while you're skiing, while you're out biking, while you're out running. It may happen in the shower, and all of a sudden that use is going to flow through your existence. You go, wow, yeah, that should work. And you need to write that down. Keep a pen and a pad next to your bedside. So if that idea hits in the middle of the night, get up and just scribble it down, because I can guarantee you will not remember it in the morning. Moving on, Gandhi, there's more to life than increasing its speed. Again, you got to slow down a bit to create a few factors in that regard. You need to be aware of everything around you. You really need to look, if you will, observe things. I say you need to outvent. You need to be able to get away from your work. You can't just try to bore into it forever. You need to go out, take that ride, go for that bicycle, take that vacation. Because in point of fact, that's where you're going to solve some of your biggest problems. View the situation from all angles. Turn it upside down. Take the knowledge you have and pretend that what you know is true isn't, and how would the world look that way? I destroyed one person who interviewed for our residency program, who asked me what I was looking for. And I looked at him and I said, well, I need to find an individual, see an apple, know that it's an apple, but imagine it as an orange. That was the end of the interview. But people want different things. But this is where you get into great physicist Feynman, bigger is better. He said, no, let's go smaller. Warren's stuff on no acid, no ulcer, wrong. It's all bacterial for your peptic ulcers. Then lastly, what did Winston Churchill have to say? Success consists of going from failure to failure without loss of enthusiasm. And that's key, because each failure is more knowledge. More knowledge. There are no negative results. There are no negative results. Every result is positive new knowledge. When somebody says, no, this can't be done, never accept the word no. No is not an answer. No is an invitation. No is the first step on the creative path. Each change in the planned course of events is an opportunity for discovery. This is Lilla High, drown your sorrows over a beer, and you discover the tubing for cardiopulmonary bypass. This is what happened to see Walt Lilla High in Minnesota, and they figured out how to do the bypass, but they were looking for tubing, and lo and behold, the tubing they used was the tubing they found in a pub where they're basically making beer. This is classic. Find a putrid sandwich left over and discover penicillin. This is Fleming. Anybody else in the lab would have just thrown the sandwich out. Fleming went, whoa, look at that. My sandwich is rotten, but there's no bacteria over here. Why is that? Look, be aware. And then you really need to be lucky in your mentors. I've been very fortunate throughout the years. Elwin Freddy, who, may rest in peace, is my boss when I did my residency program, was incredibly supportive. And then I had the good fortune to basically run into Art Smith. He came from South Africa and came directly to Minnesota. And Art had this idea of trying to dissolve stones, which eventually became endourology. And then my best friend, Dick Williams, who was just amazingly supportive throughout my residency. And also Paul Lang, who was a resident at that time. Fabulous mentors and friends to this day. And then you need to be lucky in your colleagues. Working with Lou Cavusi is fabulous. Lou is just amazingly stimulating, if you will. Anyone who knows Lou understands that. And then Elspeth McDougall, who is just one of, I think, the best educators that I've ever met. And all the courses and everything else like that could not have been done without Elspeth. We did a ton of cases together. And then now you need to be nice to people on the way up because you can see them on the way down. That's really, really true. So now my boss is Jamie Landman, who is a former fellow, and working for Jamie has allowed me to continue to do these innovative things and creative things. And this is the most important thing. You need to marry well. That's the person who's really going to determine your success or failure in life. This is the person who's going to pick you up when you've been basically knocked to the floor, dust you off, put you back up. And that's key. And then family first. All this stuff is really interesting, but at the final analysis, it's family first. So in conclusion, a few things. Be open to the change. Understand when somebody's asked the seminal why. Think about the innovation factors, emotional, the practical, the personnel, who are you and the personnel around you. Understand the three tipping points, the discovery, the development, and the dissemination. Know yourself, know what your strengths are, and seek to find people who complement those strengths, and seek out first-rate mentors and colleagues, and most of all, marry well. So in the final analysis, William Saroyan says, in the time of your life, live so in that wondrous time, you shall not add to the misery and sorrow of the world, but shall smile to the infinite delight and mischief. And medicine and surgery is an ongoing mystery, begging you to smile, enjoy it, and solve the problems. Thank you.
At what point in laparoscopy did you see a big improvement in like the visualization? And what was it? Is it just the equipment?
The equipment got better. So it was not necessarily, and the cameras got better, and then the equipment got a lot better. You know, the ligatures came out and all this other stuff. I mean, because early on you had no idea. I mean, the mistake that we made was that we went from the animal straight to the human. We missed the cadaver. Had we gone from the animal into cadavers, we would have been able to work things out much better. But we went from a situation where it was like operating in pediatrics, where they're in a child where there's no retroperitoneal fat. And you look and you go, well, yeah, there's the kidney and there are the vessels. Why not? To a situation where you look and you go, I have no idea where it is. And then you go, oh yeah, there's the colon. We got to reflect the colon. You know, and you went through this process of, you know, if we hadn't had the ureteral stent up, we would have never been able to do it. And then over time, things developed. We went, okay, you need to take down the linotope this way. You need to take down the triangular ligament, coronary ligaments, liver that way. And it slowly evolved. But the first case was like, yeah. And that's, I didn't realize that till years later. We should have gone from the animal to the cadaver, then to the clinic. But
you know, we have a lot of ideas sometimes in residency we think about for patients or in our view. Even like we were talking about yesterday, about subcutaneous bypass. Sometimes things are so niche. You know, what advice do you have in terms of like approaching industry, making something, you know, be widely available because our field is so niche, and trusting people from the industry, economics. That's what I find.
well, you know, if you get into the thing, this is my idea, it's worth $1 million, blah, 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 you're dead in the water. You're just dead in the water. The bottom line is, again, my philosophy, trust everybody. And let somebody prove to you that they're not trustworthy, rather than trusting no one. Okay, so you just trust everybody. Are you gonna get screwed a bit? Yeah, big deal. It's not gonna kill you. You get up and you move on. But if you are in the mode of trusting nobody, you go nowhere. You go nowhere because you're so paranoid all the time that someone's stealing my idea. This is, and you become so, but this is my idea. Screw it. Doesn't matter whose idea it is. Is it going to make things better? And if it does, you'll get enough credit. So you don't want to get tied up. And as you go along, write these things down. I mean, when I was a first-year resident, I had just come off of my internship, rotating on cardiothoracic, and we had gotten, in addition to flush toilets, we had gotten the very first flexible bronchoscopes. And I went from doing bronchs in the OR under topical cocaine anesthesia with the Chevalier-Jackson rigid scope, right? 2 drops for the patient, 3 drops for the surgeon. All of a sudden we're doing bronchs in the ICU. Flexible scope. Wow, that's incredible. So as soon as I got on urology as a first-year resident, my first question was, where's our flexible cystoscope going? And they look at me and say, just shut up, you need to learn how to use this. Okay. And I used that for 4 years. But then as soon as I became junior faculty in Minnesota, I went to Cahill, pulmonologist. I want to borrow your bronchoscope. She was a good friend. So we started doing flexible bronchoscopy of the urethra in urology. And then we did a prospective study where one urologist would come in and do rigid, record all the findings. I'd come in and do flexible, record all my findings. The nurse would record how comfortable it was for the patient. And then we compare the findings, and that showed that, yeah, the flexible was every bit as good as the rigid. And when it came to looking at the bladder, it was far better. But that was just something that, yeah, 4 years later, I was able to act on. 4 years. So these ideas, when you know your chief goes, just learn what you need to learn. Fine, that's a seminal why. Write it down. Don't lose it. And then when you get to a position, you'll be able to act.
That's an excellent talk. Thank you very much. And as I was sitting here, I thought that we should make this, your slides, a requirement for the reading of every resident when he finishes his residency, especially when they go into an academic. It's all there, and it's step by step. Thank you very much.
Yeah, well, I mean, you know, this is the thing. I mean, it is an amazing privilege to have an opportunity to perhaps, and I tell people, you know, how do you justify your life? Academically, how do you justify your life? To my mind, my work mind, you justify it as soon as you discover one new piece of information that you put into that quilt of academic knowledge, or brick of foundation of knowledge. You've just justified your life. Because if you hadn't been born, that brick would have never been placed. That foundation would have never gone forward. So it's very heady stuff, but it's really, really cool. And then you have other people build on it. and you celebrate their success as they go forward. I mean, you know, people go, "Oh, are you really upset about the robot coming on because it killed your laparoscopy?" No, I think it's great. It's allowing more people to operate laparoscopically than ever before. The robots are fabulous. Now, the robot would never have come on if the laparoscopy didn't explode, because the robot needs fixed points in order to work. It could not work necessarily in an open field. So the laparoscopy set the stage for the robot. The robot now has allowed laparoscopy to go forward.
Ralph, I really enjoyed your talk. I remember when I first came to St. Louis in 1999, I was in your office, a little cartoon, last year bookcase. It says, "There is no finish line."
Yeah,
Do you still have that?
that is still framed on my wall. It's a Nike poster. Yeah, it's an old Nike poster. Yeah. And apropos of last night and the resident graduation, and that sign was in my office all the time. We had one resident, it was Don Miller, who, when he got up to give his speech at graduation, finished it by saying, "Dr. Clayman, I just wanted to let you know, there's the finish line, and I've crossed over." Yeah, great stuff. But yeah, it's an amazing privilege. What you're being allowed to do is just really, really special. Really, really special. There's not another profession in the world that can provide you with the fulfillment. It's an honor for me to be here. True honor to have been the Lytton visiting professorship, because I went to Lytton. Read a little bit about Clyde Deming, and I know that he was a major force in prostate cancer. So maybe that's inappropriate for me, but at any rate, and it's just a pleasure to be here and, you know, spend time with Bob, and especially gratifying for me to see Isaac